Welcome to this explainer. Okay, today we are diving right into the nuts and bolts of exactly how to calculate and report the improved outcomes metrics under the SASB standard for managed care entities. We're going to be looking specifically at metrics HCMC-260A.1 and .4. We'll break down exactly how you track and report the percentage of enrollees participating in specific wellness programs. We're talking diet and nutrition, exercise, stress management, mental health, and smoking or alcohol cessation. And importantly, we'll look at why proving the effectiveness of this care is absolutely crucial for protecting and growing your enterprise value.
Here is our quick roadmap for today. 1. The value of improved outcomes. 2. Defining wellness programs. 3. Calculating enrollee participation. 4. 6 wellness program categories. And 5. Beyond the numbers.
All right, Section 1. The value of improved outcomes and why enrollee wellness matters to enterprise value. Now, you might be wondering, why on earth does a strict financial and sustainability report care so deeply about things like diet, exercise, and stress management? I mean, historically, financial reports focused purely on dollars and cents, right? Well, in the managed care industry, your product is actually the health of your enrollees. Their physical and mental well-being is literally and inextricably tied to the financial health of the organization itself. So when investors are evaluating your enterprise value, they need to know you are actively managing the root causes of medical expenses, and that all starts with individual health. The stakes here are incredibly high. It's a real make-or-break situation. When managed care entities actively maintain and improve enrollee health, those positive impacts compound, right? We're talking increased market share, improved margins, and even bonus payments linked to reimbursement rates. But conversely, if an organization fails to deliver high-quality outcomes, they face some really serious material risks. Decreased market share, regulatory fines, suspensions, and a massive spike in legal costs. So tracking wellness, it's not just about good public relations, it's about fundamentally protecting your enterprise value. Moving on to Section 2, defining wellness programs and establishing the parameters for your disclosure. Before we calculate anything, we have to know what counts. And the standard is actually very clear, defining these programs through a strict dual lens. An initiative only qualifies if it actively encourages either primary prevention or secondary prevention. So it's not just about handing out a generic gym discount code or emailing a healthy eating pamphlet. It actually has to fit into these rigorously defined strategic buckets of proactive health management. This definition acts as a strict filter, really separating true clinical impact from surface-level marketing.
Think of primary prevention as stopping issues before they even start by promoting healthy behaviors. The source data specifically calls out initiatives like immunizations, structured exercise programs, smoking cessation, and maintaining a healthy BMI. Secondary prevention, on the other hand, is all about active medical intervention. It's promoting early-stage disease detection and management through clinical screenings. This strict distinction makes sure your reported data captures genuine, clinical-grade preventative efforts, rather than just casual lifestyle suggestions.
Section 3. Calculating enrollee participation. Let's master the math for metric HC-MC-26A.1. Okay, to calculate your participation rate, you've got to meticulously follow 3 specific steps. Step 1 is identifying your numerator. This is the number of unique individual enrollees participating. The big operational challenge here is data integrity. You absolutely have to ensure there's no double counting across your disparate claims and wellness platforms. Step 2 is calculating your denominator, which is your monthly average number of enrollees. And then step 3, you just divide the numerator by the denominator to get your final percentage. But hey, that's a denominator in step 2. We need to take a closer look at that. The absolute crucial factor for your denominator revolves around the number 12. The standard clearly states you must calculate the monthly average by taking the total number of member months, which means one member enrolled for 1 month, and dividing that total by 12. You can't just take a convenient single snapshot of your enrollee count on December 31st and call it a day. Dividing by 12 forces you to smooth out the data, perfectly accounting for churn, new signups, and cancellations. It gives investors a highly accurate, totally unmanipulated picture of your base. All right, Section 4, 6 wellness program categories. Let's look at the specific buckets required for reporting. Now, here is a critical compliance rule you cannot miss. Percentage participation must be disclosed individually for each of the 6 specific program types. There's no way around it. You are not allowed to just lump everything together into one big, impressive-sounding aggregate number. Transparency is mandatory here so stakeholders can see exactly where your preventative care investments are actually going. And here they are, the exact 6 buckets required by the standard. You must run that participation formula we just talked about for 1, diet and nutrition, and 2, exercise. Now notice how the standard distinctly separates 3, stress management, from 4, mental health. This is a big deal, recognizing that clinical mental health support is totally distinct from general stress reduction. Finally, you have 5, smoking or alcohol cessation, and 6, all other wellness programs. Segmenting your data exactly this way reveals where your organization is heavily investing resources and which specific health challenges your population is truly facing. And finally, Section 5, Beyond the Numbers, fulfilling the qualitative narrative of HSC MC 260A.4. Let's be honest, in the world of managed care, a flat percentage just doesn't tell the whole truth. Because quantitative data alone isn't enough, metric HCMC 260A.4 is designated strictly as a discussion and analysis metric. This means it requires a comprehensive qualitative narrative. This is your big opportunity to tell the strategic story behind those percentages we just calculated, explaining the real how and why of your wellness initiatives to regulators and investors. To fulfill this, your disclosure needs a really robust narrative. Think of it like a checklist. Who exactly are your target populations and what risk factors are you addressing? What actual strategies are you employing to promote preventative care? And crucially, how are you driving enrollee engagement? The standard also wants to know about your care delivery models, like how are you coordinating all this care? And finally, you have to prove your monitoring methods. How are you using KPIs, patient feedback, and benchmarks to evaluate if these programs actually work? This narrative is literally where you prove you're actively managing outcomes, not just, checking compliance boxes. So, as you gather your data, run your denominator calculations, and draft that qualitative narrative, ask yourself, how does our wellness data tell the larger story of our enterprise resilience? These SASB metrics aren't just annoying compliance hurdles. They are a mirror reflecting your organization's long-term viability. Are your programs truly improving lives, or are they just existing on paper? Getting these calculations right is the very first step to answering that question. Thanks so much for joining me on this explainer, and I really hope this roadmap helps you approach your reporting with total confidence.